Welcome to the respiratory system. So the more obvious functions of the respiratory system are inhalation and exhalation. Inhalation and oxygenation. Many of the functions of the body require oxygen as a source of energy. For example, muscle contraction. But the oxygen originates in the atmosphere, in the air. So as we inhale, we draw in the oxygen, and then this oxygen is delivered to the bloodstream via gaseous exchange. On the flip side, exhalation and elimination. CO2 is a waste product within the body. So when we exhale, we actually exhale the carbon dioxide, or the waste product. So this exchange of gas, that oxygen brought into the bloodstream and the CO2 returned from the bloodstream to the air, the expired air, via CO2, is a process called gaseous exchange or respiration. So removing the CO2 from the body also impacts the pH balance of the body. The production of sound is another less obvious function. Airflow and the pressure through the larynx creates the sound and our voice. And also breathing, respiration, increases venous return and lymphatic drainage. That constant expanding, relaxing of the thoracic cavity helps to create a vacuum and pump effect, which aids in venous return and also in lymphatic drainage within the body. So that is a side function of the respiration system. Let's take a look at the anatomy of the respiratory system, starting with the nose or mouth, where the air is inhaled or exhaled through. We then come down to the pharynx, this muscular funnel, and it's made up of three sections. The nasopharynx, and this is where the air comes through that is entered through the nose and allows the air to travel down into the lower elements of the system. We then have the oropharynx, similar function to the nasopharynx, but it's found at the posterior oral cavity where the air comes in via the mouth. And that comes down to the laryngopharynx, so that last border with the larynx itself. And this is where it meets with the epiglottis. The epiglottis is a rather amazing feat. It is a flap which switches between access between the esophagus for the digestive system when we're eating, or into the trachea for when we're breathing. The epiglottis is actually part of the larynx. As you can see, it's right here at the top. And the larynx, which is also known as the voice box, links the pharynx with the trachea, that tube that delivers the air down to the lungs. The larynx is located at the front of the neck, the anterior portion of the neck, below the hyoid bone. And the epiglottis, as I said, forms part of the larynx, but also the thyroid cartilage and the cricoid cartilage and the vocal cords all form part of the larynx. Now the trachea extends from the larynx down towards the lungs. It's around 11 centimeters in length and it splits into two at around the level of T5, the T5 vertebra, where it becomes the left and right bronchi. It's made from cartilage and smooth muscle, and this is to prevent it collapsing from the changing pressures on the inhalation and exhalation. Now the bronchi are split into the extrapulmonary, so extra outside of or extra surplus to, extrapulmonary bronchi, which are found outside the lung, and then the intrapulmonary bronchi, which are found inside the lung. These split further into tertiary bronchi, which then form tiny bronchioles. As the bronchi split, their constitution becomes higher in smooth muscle and lower in cartilage. They become softer, and they are served by the autonomic nervous system, so they happen automatically. They're smaller in size to the trachea, and larger particles that pass through the trachea can get lodged in the bronchi. So let's rewind and talk a little bit about the lungs in which those bronchi and bronchioles sit. The lungs are two organs located within the thoracic cavity, one on the left and one on the right. They're surrounded by a membrane that provides them with enough space to expand as they fill up with air and contract as the air is exhaled. The left lung is smaller due to its proximity to the heart and has only 2 lobes, whereas the one on the right has 3. The lungs are filled with millions of small sacs called the alveoli. The alveoli are found at the ends of the bronchioles. We can't see them in this diagram. They're indicated here, but they're the tiny millions of little sacs that sit within the lungs. And they're surrounded by capillaries through which the blood passes. So they're almost swimming in those capillaries. And this is where the gaseous exchange takes place. So because they are so small and surrounded by those capillaries, that is where this gaseous process will take place. And we'll go through that process in a little more detail. So first, let's talk about the mechanics of respiration, as this is really linked to a lot of what we do in sports massage and a lot of the reasons as to why you will work with the breath as part of your sports massage treatments. So first of all, let's talk about relaxed breathing and how that happens, that autonomic relaxed breathing. And then also, let's talk about forced inhalation and exhalation. Again, autonomic, but that exhalation that happens when we're under pressure, under stress, high intensity exercise, for example. Different muscles are used, and that might give you clues to the various aches and pains that your clients have in relation to the respiratory muscles. So for relaxed breathing, when we inhale, the external intercostal muscles between the ribs and the diaphragm contract. That contraction of the diaphragm actually pulls it downwards, as we can see in this diagram here. It contracts, it actually flattens it out, pulling it downwards, creating that vacuum to inhale or pull the air inwards. It pulls the rib cage upwards and outwards, increasing the thoracic cavity volume. And that decreases the pressure inside, pulling the air inwards. Gases move from areas of high pressure to areas of low pressure. So as the pressure lowers inside the lungs, it pulls the gas inwards. Now, on relaxed exhalation, this is usually a passive process. As the intercostals and the diaphragm relax, the diaphragm raises, that volume decreases, pressure increases, and the air pushes out. We exhale. So we move from that area of high pressure, which is now the lungs, to an area of lower pressure, which is now the atmosphere. So what happens on forced inhalation? So during exercise, for example, a more forceful inspiration is required. But this can also happen when we're stressed and anxious, for example. Serratus anterior and posterior get involved. The SCM, so those muscles of the neck, sternocleidomastoid. The subclavius beneath the collarbone. Pectoralis minor, which sits below the pectoralis major and attaches to the ribs. And also the quadratus lumborum, which attaches to the 12th rib. So all of those muscles are involved on forced inhalation. And then what happens on forced exhalation, which again, generally relaxed exhalation is passive. On forced exhalation, because the breathing rate is increased, we want to exhale at a quicker speed, so muscles get involved. The intercostals contract to reduce the thoracic cavity, transversus and rectus abdominis contract, as well as the obliques. And again, that quadratus lumborum on that rib 12 fixes that rib as well. So suddenly, a lot more of those small accessory muscles and core muscles start to get involved when we talk about forced inhalation and exhalation or under stress. So let's come back to the key to this system, the gaseous exchange. This system, the respiratory system, is vital in getting that oxygen from the atmosphere, not only into our lungs, but more importantly into our blood to be delivered around the body. And we've got to go a little bit sciencey here to talk about how that happens. Dalton's law is a law that states that each gas in a mixture of gases exerts its own pressure, behaving as if it was the only gas there. So although we have, for example, oxygen and carbon dioxide in the air, they can act independently of each other. So for example, we can extract just the oxygen from that air, or push, for example, just the carbon dioxide back. So they can act independently. Gases move across membranes. Now we've talked about membranes in many of our modules where there are differences in pressure. So for example, gases move from an area of higher partial pressure to an area of lower pressure of that gas. So let's talk about this really simply. We've just inhaled. We've got that air we've inhaled in the alveoli. So we're right down at that last part we talked about in the respiratory system, where that alveoli is in contact with the capillary. Now, we've used up all our oxygen. We need more oxygen. So we would expect that the partial pressure of O2, oxygen, in the blood is low. But it's high in the alveoli because we've just inhaled. Now, if we use this law, gases will move from that higher pressure, partial pressure of that gas, to an area of lower partial pressure of the gas. So by simply being in contact, the lungs being full of air, the blood needing more oxygen, that oxygen will cross the membrane from the alveoli, cross the membrane of the capillary, the wall of the capillary, and into the bloodstream. Conversely, that blood is rich in carbon dioxide. We've used up most of the oxygen, whereas the air we've inhaled is lower in carbon dioxide. Again, higher partial pressure of the carbon dioxide in the blood, lower partial pressure within the alveoli. So that carbon dioxide, that excess CO2 that we want to eliminate, will move through the membranes of the capillary, the walls, the membranes of the alveoli, and into that pressure, that gas, that area of lower CO2 pressure in the lung, ready to be exhaled. Don't let this process overwhelm you. Just know that that higher partial pressure, a gas where there's higher partial pressure, will move across a membrane to an area of lower partial pressure. And by using this Dalton's law, that explains why when we inhale, that oxygen-rich air moves the oxygen into the oxygen-low blood, and the CO2-high blood moves into the CO2-low-high air. And then we exhale. We eliminate that from the body. So what do we call these processes? External respiration. That is the process of taking oxygen from the environment into the blood. This involves mechanical respiration or inhalation to bring fresh air into the lungs, where then chemical respiration takes place. The chemical respiration is at this level, the exchanges of gas. The carbon dioxide in the blood that moves from the blood where the partial pressure is high into the alveoli and the lungs where the partial pressure is low, as we've talked about before. And that is what we call external respiration. Now, internal respiration. This is the delivery of the oxygen to the tissues of the body. Internal respiration isn't about an inhalation and exhalation of air from the atmosphere. It's about delivering that oxygen to the body and the collection of the CO2 waste product from the tissue of the bodies to bring them back to the lungs. That's what we call internal respiration. So the hemoglobin in the red blood cells carries both the oxygen and the CO2 around the body. As the blood runs through and around the metabolic tissues in the body, the oxygen is diffused from the plasma into the cells of all the tissues that it comes across. And the carbon dioxide is diffused out of the cells via the membranes and into the blood to be brought back to the lungs, where it can be eliminated via exhalation in this process. Exhaled air is about 4 to 5% less oxygen and 4 to 5% more carbon dioxide than inhaled air. So it's about 15% oxygen on exhalation, where it's closer to 20 on inhalation. So how is this complex system controlled? We breathe tens of thousands of times a day, but it's not really something you often think about unless you consciously do some breath work. It's controlled in two neural pathways, one voluntary and one involuntary. So voluntarily, nerves from the cerebral cortex communicate with the motor neurons that serve the respiratory muscles. That allows us to take control of the pace and rate of breathing for singing, speaking, or even as mindfulness techniques and means to control anxiety, for example, by slowing down our breath rate. And that has a knock-on impact on slowing down heart rate, for example. But mostly it's involuntary. It's an autonomic nervous system response. There are 3 respiratory centers in the brainstem that are responsible for this. The respiratory centers are networks of neurons which rhythmically discharge impulses to the respiratory muscles to ensure that we keep on breathing. So what has breathing got to do with musculoskeletal dysfunction and even posture? Breathing dysfunction can lead to postural dysfunction or musculoskeletal dysfunctions. But equally, postural dysfunctions can lead to breathing dysfunctions. So take, for example, in this first example, someone who is stressed. Breathing rate increases. They start using those muscles of forced inhalation and exhalation on a daily basis, tens of thousands of times a day. Muscles of the neck tighten, muscles of the chest tighten. That changes, perhaps, how that person's spine is aligned. Tight neck muscles, increased kyphotic curve in the thoracic spine. Knock-on impact of that is potentially increased curvature of the lumbar spine, lordotic spine. So again, what starts as stress and change to breathing pattern can have a knock-on impact as to how that person holds their posture, holds their body. That doesn't necessarily cause pain or injury, but sometimes it does. And by improving breathing function, it will have a knock-on impact on those things. Equally, someone who spent most of their life upright moving around gets a desk job, starts sitting in front of the desk for hours and starts to change how they hold their body or their posture. Again, perhaps not always, this increases that kyphotic curve, lordotic curve, and decreases the volume of the thoracic cavity. Maybe it's harder to get a full breath. Maybe they start to use some of those muscles, accessory muscles of inhalation and exhalation, leading perhaps to tight neck, tight spine, reduced mobility, impacting musculoskeletally, and maybe being part of the issue in terms of their musculoskeletal problems that they come to you with. So we will use the breath for many reasons, primarily to stimulate that parasympathetic response that we talked about in the nervous system. But it's also a useful tool for stretching and for applying techniques to many of these muscles that are hard to access by using the breath to stretch them, especially when we start talking about soft tissue release, for example. But also, breath work can be a very powerful homework tool or home care tool for your clients. Changing how they breathe can have a knock-on impact on how their body feels from a musculoskeletal point of view. Breathing and well-being. So on the first point here, we've talked on the previous slide, but research has also shown that ineffective or inefficient breathing could result in muscular imbalance, motor control alterations, and physiological adaptations that are capable of modifying how we move. So of course, breathing and breath is something we should be looking at in our clients. But also it runs deeper than that. Research has shown, for example, that in older patients with kyphosis, that there's an association to dyspnea and ventilatory dysfunction of a restrictive and an obstructive type, having a direct impact on their health. Shortening and spasm in the diaphragm can cause dyspnea and chest pain. Lots of research out there that shows breathing patterns are related to anxiety levels and an increase in respiratory rate on physical load. So even just looking at things like stress response, anxiety, conditions where our sympathetic nervous system kicks in, that fight and flight response, increasing breath rate, increasing heart rate, then breathing becomes key to this, as breathing is one of those responses that we do have voluntary control over, but it needs to be a conscious effort. So breathing exercises can be useful. Research indicates that patients presenting with chronic neck pain, and you'll see plenty of clients like that, have a predisposition towards respiratory dysfunction. So always worth having a look at their breath, have a look at their breathing rate, and again, breathing exercises can sometimes be a really, really good supplementary home care for your clients. So let's talk about some of the common pathologies of the respiratory system and what they mean for massage. Pneumonia, cough, difficulty breathing, rapid heart rate, fever, feeling very unwell. This is contraindicated in acute stages, and I'm pretty sure if your client has pneumonia, the last thing they will feel like having is a massage. Tuberculosis, symptoms coughing up blood, chest pain, pain with breathing or coughing, and can also be accompanied by weight loss, fatigue, and fever. This is contraindicated until the client has medical clearance. It is also highly contagious, so it's an absolute contraindication for massage. Bronchitis. So this is an inflammation of the lining of the bronchioles. Again, in its acute stages, massage is contraindicated. Sinusitis, more common. This can be attributed to things like facial pain and headaches that go hand in hand with this condition. Inflammation of the sinus, generally following a respiratory infection, or also allergies. Massage has been shown to be helpful in chronic cases of sinusitis. So what does all this information about the respiratory system mean for massage? Well, 1. Massage and working on the muscles involved in breathing can be helpful for people with respiratory disorders. Some disorders that result in a buildup of mucus in the lungs, for example cystic fibrosis, but also lingering chest complaints and colds, then percussion type techniques gently over the rib cage can be useful. Incorporating breathing techniques, not just in your work, but also in terms of your home care, can help with postural related pain and dysfunction. Also in clients who are quite stressed, anxious, where they have this tightening of the muscles around the neck and rib cage, then breathing techniques and incorporating breath work into your techniques and using the breath in your techniques can be really, really effective. Note that breathing difficulties can often be made worse or aggravated by lying flat. So prop your client up if your bed allows you to do so, or by adding additional pillows or a foam wedge. Or if more comfortable, perhaps treating your client in a seated position or side lying might be more suitable.